Okay, sorry for that rushed lunchtime. You can continue eating while we're chatting up here, though. I would just like to comment that I just felt that those table discussions were wonderful, and the buzzing and commentary that was going on at each table was just great to see. I think 100% of you were engaged in that. So thanks to all of you, and thanks to the facilitators. We're going to have each of the facilitators report back now. It's a short time that we have. They'll have 3 minutes. I'll let them know when there's 1 minute to go. And we will go through each one and then have a brief question-answer period, at which time the facilitators can answer or refer back to their tables. So we'll start with table 1, Elizabeth Hawkins Walsh, and she's going to talk about the lever of change, which is implementing multi-generational surveillance and interventions.
Okay.
You have a mic? Thanks. And maybe I'll have you stand, if you don't mind, Elizabeth. Thanks.
We had a little bit, can you hear me? Okay. We spent a few minutes discussing what really multi-generational surveillance meant, but we think we came to some consensus. So when we thought about what it would be important to achieve, we got back to some basics and talked about competencies, having trainees, and this is in training, obviously. How do we improve the training of our trainees to achieve this? Good competencies around family histories, multi-generational family histories that would truly identify areas of need for health promotion and risk prevention based on these histories. We're concerned that too many of our practitioners really don't know the family histories of the children that they are seeing. They may begin to know them a little bit after problems have been identified, but moving forward in a universal way, we don't think this is happening, that there is a comprehensive family history. So helping trainees identify, being competent at doing this, as well as understanding the value in it. Also, we hope to achieve early on in our trainees a sense of self-identifying as a team member. And maybe we can talk about that a little bit in another minute when we talk about some of the barriers and challenges. But we've talked a lot about the need for interprofessional teams, for this expanded need for team members working side by side if we're going to make improvements in addressing these mental health needs of children and families. And we know that the trainees need to know how to work in teams. We think they need to self-identify as a team member very early in their training, not later when they feel perhaps ambivalent about having to share responsibilities with other providers. So having this sense of being a team member very early on in a trainee's education. Some of the barriers and challenges that we recognized are that there are a lack of adequate quality clinical training sites for trainees where they can see these competencies being practiced, and that's a very crucial part of their training, what they see happening and their opportunities to practice these skills in clinical opportunities. We also saw some barriers as potential competition amongst trainees. We talked about the interprofessional common competencies, the core competencies which are common, which can be an asset but also can lead to some role confusion and some sense of who does what and who owns what part of the problem, and so that the competition among trainees can be a challenge to overcome. Another challenge certainly has to think about funding and reimbursement, which we know is changing and is a big unknown right now. But we do know as an opportunity that there are, or there have been, some new funding mechanisms, at least with Medicare, et cetera, through value-enhanced primary care, some recognition of funding opportunities for bringing population-based approaches into a primary care practice and getting value-enhanced reimbursements. So we don't know, obviously, whether those kinds of opportunities will grow or shrink or disappear altogether. Other opportunities that we see are related to some excellent experiences some have had with new ways of training our students through the use of simulation, through the use of OSCEs, our objective, structured, standardized clinical evaluations, where we're able perhaps to embed some of these competencies or these experiences with multi-generational families could be created with OSCEs and reshape some of the students' narrow experiences. We also talked about some models that had been experienced for interprofessional training, whereby medical students and nurse practitioner teams are teamed up early in their programs for a continuity experience with a family, with a child with a chronic illness. And that was one of the models we had talked about. And my time is up. Thank you.
Thanks, Elizabeth. Sorry for the short time we have. Hendrix is going to talk about incorporating evidence-based practices into training, and Sarah has the unenviable job of letting you know when your time has come to an end. We all loved you, though, Hendrix.
Yeah, our group was very diverse, and we had no shortage of ideas and no shortage of words, but we tried to put on a few of the words in here in terms of the key points we had. The group that we had broad backgrounds in nursing and public health and child psychology, child psychiatry, population-based approaches in here, addressing issues in health disparities, and it was a wide, rich group of people who were involved in our presentations in here. So we talked about these issues about evidence-based practices, and part of the discussion, probably it happened in other groups in here, flowed beyond that particular domain. We started getting into, it's not necessarily sufficient just to talk about evidence-based practices in here, but the learning that you get about what those practices are is not necessarily going to get you to be implementing those in the real world settings. So we started to talk a little bit more about expanding beyond this to include principles of prevention and issues addressing implementation and improvement science as well. We thought that that was a broad set of topics in here that would be necessary in here for particular training programs, particularly in the professional fields in here, but also in other areas. So we thought it was important to achieve that standards and licensing and accreditation for professional groups in here include prevention practices and evidence-based programs in here, as well as implementation. Also, that there has to be a payoff. And one of the payoffs in here is reducing unnecessary medical services and reduce costs associated with those by using evidence-based programs. And that's the result of trying to do that deliberately, and I think it's important as a goal in here. And the third is that we don't yet have a really good structure for disseminating successes, progress, as well as failures. What do we need to learn in here about what kinds of training models will work? We also thought that the existing training models are not sufficient. When people are trained who have been in the field for 20 or 30 years, they're really not clear necessarily being trained in the kinds of models that are appropriate for this next generation of evidence-based kind of programs in here. So we think it's important to come in here. Obviously, issues around financing and structure of healthcare that is not emphasizing prevention, for example, is one of the important barriers to try to overcome. Other ones is that the curricula for many of these programs are already very packed in here, so if we're really talking about changes in here, something needs to be either integrated or dropped. Opportunities in here, we thought really an important one is to do investments in undergraduate programs around, particularly around prevention. What are the programs that actually work in here, and how do you frame that? Also, we need a model in here for existing workforce. We had a lot of discussions about that one. We thought because social work is a special group that delivers a lot of the programs in here, we thought that it's important to use that. The curricula does seem to exist in here, but it really needs the market pressures in here to say evidence-based programs are successful.
Thanks, Hendricks, very much. There obviously is a lot more to say than we're taking the time for. Joyce, if you could talk about fostering a future integrated interprofessional care.
Thank you. So we talked a little bit just about what this language meant, and I think we probably reframed it a tad, just fostering a future of integrated, interdisciplinary, kind of cross-sector professional care through a variety of approaches or mechanisms. And the list that we started with was this co-location, integration, co-management, efficient and effective handoffs. And we also talked a little bit about, we had some different figures, but the idea of different levels of integration, from the practice level to the organizational or institutional level, as well as the idea that about 30 to 40% of our health outcomes are not related to services, but are related to where we live, learn, work, play, and worship, as well as other parts. We're also fortunate to have a broad array of folks, including we had representatives from our family and youth organizations, which was very helpful. So important to achieve. We talked about using information or definitions. This question of what are we talking about came up real fast, because there are different examples of what integration means and what it looks like. So we discussed that a little bit and talked about the definitions from AHRQ and SAMHSA's 6 levels of collaboration and integration, and how important it was to have some shared framing around and concepts about what integration is about, that we're really looking at system and culture change as well as development of infrastructure that leads to that integration that we're aiming for. We also talked about incentivizing integrated care through accreditation, through licensure, credentialing, and through payment mechanisms tied to family, people, financial, and other broad types of outcomes. Barrier-wise, we talked about how so often we have this just do it mentality, and it's not always based on, and so some of the discussion included some of these kind of just do it models that didn't even include training with, and didn't include attention to financing and sustainability afterwards. We talked about the need for time to do integration and collaboration, that it is a resource and it needs to be, infrastructure needs to be in place, and that's often a challenge or barrier. One size doesn't fit all is clear, and that different models are needed in different situations and different levels. And also that there's a disconnect between educational services in terms of training people in the field and the community field placements. One of our, several of our team members talked about, some of our team members talked about, training and kind of best practices and integration models, and then going out to placements where there was a clear disconnect between what the training was and what they were experiencing, and their belief that they are kind of self-rating themselves, these placements, much higher than what the reality is. And then finally, in terms of opportunities, developing education and clinician models that embrace this idea of we are whole people, we are one body, and that you can't separate our overall health from our mental and behavioral health, and that's really kind of a concept around patient, family, and youth care that is really important, and focusing on that partnership between all the entities involved in that whole health piece. Fidelity to that notion that there is no health without behavioral health. And also opportunities around, building on the different models, learning about fidelity, and that there's opportunities through telebehavioral health models, especially in rural areas or areas where resources are challenged, even in urban areas, and data sharing around patient care. And we've shared several stories and agreed that stories are really an important part of change, that they bring the realities and the situations to life. So thank you.
Thanks, Joyce. We certainly heard that with stories this morning, didn't we? Don, if you could step up next and tell us how the needs of children with disabilities and chronic medical issues and their families fit into this.
Okay, and I'll also ask Lauren to tap me when you see the sign there, okay, because otherwise I'll go on and on. And I also want to thank the Planning Committee for structuring the morning this way, so that the chance to get together with our small group and percolate together some of these notions really made a big difference. And in the case of this particular group, I can say all of the above, tables 1, 2, and 3, plus table 4, because we're now talking about, Tom used the figure of, in the paper, of 5% of the population. I tend to say it's more like 20% of the population are children with these various kinds of disabilities and chronic conditions. That these are really the high-end, very expensive group of children, and if a lever for change is the economics, the opportunity, the potential for high savings when there's higher expenditure is one that needs to be considered. When we talk about what we wanted to achieve, is we're looking for a totally, fully inclusive system. The notion of the separate systems for children with this disability, that disability, and they are separate somehow from the normal children doesn't work, and we're looking to reduce stigma, reduce exclusion, and build an inclusive system. We have some examples of it working in our education system in this country, and moving that over into the healthcare system would be a big factor in enhancing societal prosperity overall. We require I see there's been some editing done since we gave this in. We want to seize some promotion and prevention opportunities using the ecological framework, which we're all very familiar with and supportive of, and to bring that to bear on a system that includes consideration of this diverse but important minority population. The barriers are considerable. Obviously, there's more content for training. That takes more time, more content to be taught to more people, expanded content, and how do we fit that all in? And we want to expand to notions of patient-centered, child-centered, yes, but it was quite powerful to hear from our panelists at the beginning, all of whom were dealing with situations where there was a disability as well as a behavioral health situation, or most of whom were dealing with that, that family-centered. So the family is the patient, and that shift in mindset can make a very big difference. The opportunities are immense, and we're looking for transdisciplinary, cross-sectoral, interprofessional training, and that this can also be part of reducing stigma and promoting shared experience and opportunities for promotion and prevention. And we want to support frontline providers, whether they're in the child care system, in the healthcare system, in the education system, to recognize that that's the place where the behavioral health issues that are part and parcel of the disability experience can get addressed from early on. Thanks very much. Thanks,
Don. Bill, if you could talk about the importance of engaging patients and parents in co-promotion and how we could use that as a lever for change.
Well, I'm glad to do it. I had a very wonderful group of people working with me, and like the other panelists, I have much more to say than I can get in 3 minutes. But the reason that it's important to engage parents and patients in the co-promotion of behavioral health outcome to improve care is, first of all, it leads to better outcomes. Secondly, the important and powerful experiences need to be made sense of and can teach others a great deal and provide vital feedback. We saw many examples of that from the panelists this morning. If engaging parents well is done early, it can influence the whole care experience over the life of the child. Seeing parents as experts strengthens the family and helps with implementation, and it also strengthens the care system. In terms of barriers, many different competing knowledge frameworks, stigma, lack of mentorship in working with families, and one thing I would say that we need to think about systematic solutions so that everyone on the care team needs to be involved in this kind of endeavor of patients and parents in the co-promotion, and it's hard to get a whole system or a whole team to do that, but it's worth doing. And finally, there's silos between intervention developers and implementers in real-world communities that get in the way of achieving this. In terms of some opportunities, right now there's a lot of interest in integrating behavioral health into primary care. I think there's some very good opportunities for adding parent voices to that and youth voices. One example from someone who works in a hospital that recently started an Office of Patient Experience and wondered whether it should be changed to an Office of Family Experience. Clearly, we thought of parents as faculty members, parent advisory boards, and there are several granting agencies that require parent participation in the writing and conduct of the grants. PCORI is one example. There's some from maternal and child health. We think this is a very good model, and we need to think more fully about how to fully incentivize parent participation and how to reward it financially and otherwise. And I'm going to end on time.
Thank you, Bill. It was terrific. Lauren, if you could offer the comments from yourself and your group on accreditation, certification, and credentialing.
Sure. Okay. It's going to be interesting to see some overlap, I think, across groups, especially in barriers and challenges and opportunities. But we were talking about the role of accreditation and professional certification and credentialing, and decided that it's important to achieve agility and responsiveness to the changing needs, environments, and demographics that we see in the populations that we serve and that we need to be partnering with. And we need to have changes then to the training that moves more quickly, that can address the issues that come up, because we see that process is quite a lengthy one. We also need to increase our interdisciplinary training in a way that integrates that sort of interdisciplinarity into existing frameworks, right? We think that it's going to be too cumbersome to reinvent the wheel around training, but that each field has opportunities for better integration within it, and that would include thinking about what the competencies are, because if you don't require it and measure it well, it doesn't happen. So thinking about what are the metrics that would be needed in order to achieve the competencies we'd want to see around interdisciplinary care, integrated care. Sorry for the coughing. And thinking about the barriers and challenges to this, we talked about the numerous siloed environments that include varying resources, different languages, and different requirements and metrics within them that are not shared across the groups or fields. We don't translate them well, we don't talk about them well, we kind of do it all within our own field, and that creates difficulty in meeting our important to achieve. We also talked about the limited funding streams and the mechanisms excuse me, of funding that contribute to those silos, and that also morph over into then turf issues, right? So we don't do a good job of integrating sometimes because we want to protect that funding, we want to protect that payment source or that availability, and how we might do a better job of overcoming that feeds over into the opportunities. And I too see that we were a little bit edited, but to take the second one first, that we talked about ways of combining models that are out there doing this, of combining existing small pots of funding to create a blended funding stream that does a better job of integrating the training that needs to be done, and that, you know, kind of pulls from different areas to put it together, so more of a sharing and caring model. And then we talked about moving away from a code to pay system to the models of value-based care that exist and that might be used as those models that exist out there, that we might look at those to think about, okay, what changes in training and accreditation need to happen in order to facilitate the growth of those existing models that are you know, paying based on value and that are really measuring outcomes that way, and how might that feed back into the training and accreditation requirements and how we might shift there. So I'm not doing the best job of explaining that, but I don't want to cough anymore. So what time is it?
Thanks very much, Lauren. Kimberly, if you could talk about utilizing training in other child-serving areas.
Sure, yeah, we were talking about the cross-sector kids, or the cross-system kids. And it is gratifying to see how much overlap there is among some of our comments. So I think that's great. So in terms of why it's important to achieve this, we thought about it in terms of sustainability of the population and sustainability of the economy, really. So it's important for children and families and youth, because if we don't find a way to make these services more accessible, more responsive, then it is not only unnecessarily burdensome, but it interferes with the overall population health. So from a population health standpoint, this is critical. From the standpoint of sustaining the economy, it makes business sense. Let's face it, the inefficiency of the systems right now from the standpoint of providers and training, as well as parents and children and youth, is ridiculous. So there's just way too much inefficiency. So that was why we thought that was important. In terms of barriers and challenges, number one is the payment structure, which trickles down into all parts of the other issues. So there's problems with the payment for coordination. So if you're trying to get services across these sectors, you're going to be hard pressed to be able to pay for that under the current system. The way in which payment is now organized is around diagnosis. We're talking about prevention and promotion here. That is at odds often with the way in which payments are provided. Our billing codes are not comprehensive enough. We don't have ways to really pay for prevention. A second big area was our training models. So it's very good that our training is becoming more specialized. That's part of what happens when science advances. You learn more, you delve more deeply into it. But that over-specialization is also creating problems for being able to provide services across the sectors. We need almost a crosshatch. We need some more generic horizontal training, as well as the vertical, more in-depth. So there's over-specialization, there isn't enough focus on team training, and there's not enough focus on data savviness. There's a need for being conversant and comfortable with using data across all of our disciplines and systems, and that isn't happening. Also problems with our career paths in some areas, like the peer partners, youth partners, and residential treatments. There's no real career path or hierarchy, so that's a real problem. In terms of opportunities, lots of good ideas, and I think tomorrow's discussion will be really interesting. There's a Sweden model that provides care coordination that's oriented to the child and the family, not to the bureaucracies, not to the sectors. We decided that, frankly, we need to eliminate these silos. Let's not try to fix them. Let's eliminate them, because there's just too much inefficiency and too much heartbreak, frankly, in terms of those. So care coordination that follows the patient or follows the child, I won't use the term patient, follows the child and the family as needed, is something that might be a real important opportunity. Another one is moving from a mindset of spending to a mindset of investment. And that, too, gets us over that hurdle of are we focusing on the current set of problems, or can we get ahead of the curve and be able to prevent some of them? We talked about telemedicine and how important that is to address the workforce shortages. And then finally, focusing on team and cross-disciplinary trainings that also encompass the notion of competencies. And if we can focus more on those, then we think we'll be able to do a better job. Thanks.
Thanks, Kimberly. Kelly, a lot of people have talked about funding and reimbursement, so you could bring this all together for us.
Right. Our group was focused on reimbursement and funding, and since every single group ahead of time mentioned it as the #1 problem, tomorrow we'll invite all of you to our table. For for our goal, we thought we struggled actually with the framing of this, but we really thought that tying training and education money to actually quality and outcomes based on community needs was really the essential element. Because right now, and that's the problem we just heard identified up and down the row and most passionately by Kimberly, that our training dollars are tied to everything but patients getting better or children getting better. And so we really need to make that linkage more clear. And that there has to be equity between behavior and medical training for team-based care. When we have medical training dollars and medical services, those settings have been disproportionately funded. So eventually, that will increase the amount of money toward behavioral health training and prevention. So there are many barriers, but really all the barriers that were mentioned at our table came down to two things. One is that fee-for-service reimbursement requires high volumes and lots of service specialization and licensing and accreditation requirements, because the more of those they have, the more you make. And it's not about making patients better, it's about enhancing the guilds and the disciplines and the hospital systems. Secondly, another barrier is that medical systems, not the behavioral health side, have been at the trough for a long time. They speak with unified voice and they're very effective. So the disproportionate amount of money in the system goes to the medical system, and as we've already heard about the United States compared to other countries and things, we're all familiar with the data. So what are the opportunities? Value payment models, especially when they go clear out to capitation, and when they have tied to them metrics that matter for wellness in families, can accelerate the investment in community-focused behavioral health services. And we particularly mean metrics such as things proposed by Vital Signs at the National Academy, such as high school graduation rates, infant mortality, kindergarten readiness. Yes, many specific behavioral health things will roll up into those, but overall, when children and neighborhoods are healthy, then providers can do well, and we're doing prevention much better if we're doing those things. So advancing value payment models much more aggressively and effectively, and making sure the metrics for those are the right ones. And secondly, we as a field, especially in the health promotion and behavioral health promotion and prevention area, have not effectively employed return on investment studies, national surveys, and proof of concept sites, places where we actually go in and do change the way we do things to make it show people what it's really like when the system is working. So until we do that, we can yell from the mountaintop, but we're not going to be effective at really changing the overall outcomes. So we think there are great opportunities, but we have to act aggressively right now, especially in this time of transition.
Thanks, Kelly. So I'd like to thank the facilitators for taking some really rich discussions that were going on and need to be continued on this platform and in others, and consolidating that in such a short period of time. So thank you all very much. So we did move through that a little bit so that we would have some time for some questions. Sure, that would be great. So Hendricks has just suggested wisely that if there are comments from others at the tables regarding the comments that your facilitator made, additions, corrections. Okay, so I'd like to ask the parents from this, again, we understand there's a lot more parents in the room than we understood before, but for the parents that did speak this morning, were they, who were not were at a different table, did they have different comments about any of the things that were brought up, like co-promotion and so on, than were brought up in the brief comments that were able to be made up here? Did parents have any other things on their wish list for us? Any comments between facilitators, one to the other, asking questions? Yes.
So opportunities included team-based care and better continuity, and yet sometimes those two may, in fact, be opposing forces. The bigger the teams are, the less continuity, and I wonder if any of your groups discuss that or have opinions about how to manage team-based care within the framework of continuity.
Joyce?
I'll just make a quick comment. It's one of the things that we talked about was that concept of continuity is really critical. That one of our members at the table talked about being in a rural area and then moving, one caregiver's down 2 hours south, another's 2 hours north, or something of that sort, and that they've made some progress, I guess you can say, if that's fair, in terms of just having some ongoing communication and continuity so that families and young people don't have to tell their story 1,000 times, and how discouraging that is, but also just having that continuity that you can move from one provider to another and keep going instead of stepping back and reiterating that. So you made me think about that concept.
Thanks. Kelly?
Tom, we're having some difficult issues because we're actually downsizing some of our developmental behavioral teams that we'll see 4 patients in an afternoon and have 8 members on a team, and it's a very intensive process, and we criticize the psychiatrist down the hall who's writing prescriptions every 12 minutes, and because they have such a demand for just that specific thing. I think we have to find new ways to do that, and some of the family practice models that have won awards lately for being innovative have a team concept, but they don't meet each patient as a team. They have ways of investing each individual with the maximum allowable skill set and practice, and actually owning part of the practice. So the medical assistants own some part of the practice, the nurse practitioners own some part of the cohort of patients and community members in the practice. I mean, they each have different responsibilities and relationships without having to all see every patient every time.
Thanks. Other questions? Hendricks had a comment.
It seems to me that we have 2 real fundamental problems that I think are worth reinforcing in here. I know we've seen these slides about the shortage of the workforce in behavioral health. We had just a couple hours ago in here. I think that's fundamental that we really start to try to address that issue. And the second one is that I think we have job titles that are really not conducive to what people really need to do. And they're just really completely off the table in here. There's something like 60 million people who in this country have increased mental health service access than they had just a few years ago through the Affordable Care Act. We don't know exactly what's going to happen right now, but I bet that that's not going to disappear, and certainly the need is not going to disappear. I think we've got a fundamental piece around how do we try and invest in our country in here to develop an appreciation for the need for behavioral health to be integrated into healthcare in a much deeper way than we have before, as well as other systems such as the educational system in here. Bill always continues to remind us of the need to have the political will be really an important part of this one. I think that's the key. I think we need to have the only way to try and change this system in here, I think, is to have the people stand up and say, we demand this. We demand to have the government help us so that our kids will grow up as healthy as they can and be as effective as we can in this future in here. And I think that's the missing piece in this strategy that we really need to identify in here. And I think the parent advocates, of which everybody in this room should be, I think we've learned that, is a big part of this whole process.
Thanks. Joyce. And then Nathaniel.
Thank you, too, for your comments. I just wanted to add the piece and invite people from Table 3 to comment if I've missed anything, but bringing in the notion of these alternative settings where young people are at school, in early childhood settings, and how, from a public health perspective, every sector has, and all of us have a piece of helping children grow up well and healthy. And I always think of the idea of, we understand you can live well with cancer, but we can live well with mental health as challenges as well, and substance abuse challenges. So I think those kinds of ideas, we talked a fair amount about school and early childhood settings as places, and we'll hear more tomorrow, I think, about the workforce needs in those settings of really integrating health, education, and behavioral health in alternative settings.
Thanks, Joyce. Nathaniel?
Yeah, so one thing I wanted to bring back to is I feel like even after we solve a lot of the practice issues is making sure it gets communicated back to both the training institutions but then also the sort of prospective students, so that, you know, high schoolers grow up to one day, instead of being like a surgeon, they want to be a team-based ACO practitioner, you know, promoting wellness. Because I think there's sort of two-sided demand. There's both like what the students want to learn and then what the teachers want to teach. And so even after we've solved the sort of practice issues, I think both in sort of like culture and then in the payment, these things need to be solved. Because I do know, you know, med students tend to sort out based on the specialty payments.
Thanks. Last question.
So no, it was a comment along the line of what you're saying. So we were talking about, you had mentioned a culture of medicine, but I think what we do need to think of is a culture of health, and changing the paradigm to that for the priority on health and well-being. And as we were saying, that 70% of our health is outside of a healthcare setting. It's where we live, work, play, and pray. And this, I think, has to be infused multi-level. So we start with, you know, early childhood. We do not invest in having enriched early childhood environments, having paid maternity leave, things of this nature, which other industrialized countries do have. And we spend the most, as everybody knows, most on our health care, and we have very poor health. So I think that it's kind of a self-reflection. We talked about, you know, having an educational system where we're trying to push for interdisciplinary work, but yet in the field, it's old school. It's the same thing that's going on. And so how to incentivize this change in our culture of health. So I think that that's critically important.
Thanks. Well, again, I want to comment that, I repeat myself, I think that the discussions at the tables were so rich today, and then we compelled the facilitators to come up here and give a very short synopsis of those discussions. And those summaries should not be, that's the summary and that's the end of the discussions. The discussions should continue. They really must continue if we're going to really help to improve the behavioral and mental health care of kids. So I would encourage you to continue the discussion in the day and a half that we have left here, going back to your own organizations and institutions, take cards and questions back, write on the cards questions that you'd like us to look at further, and we'll also talk about actionable steps tomorrow. So thank you, and especially the panel, very much.